Good morning to everyone. I'm so delighted to see you all here, and a special thanks to you for respecting the time. We're very delighted to have you here for this event on universal health coverage in Cameroon. So this event has been organized by the Denis and Lenora Foretia Foundation, but most especially by the Nkafu Policy Institute. The Nkafu Policy Institute is a think tank at the Denis and Lenora Foretia Foundation. And one of the main things we do is to propose solutions, to give policy prescriptions to some of the challenges and problems we find in our Cameroonian economy. So we actually aim at catalyzing Africa's economic transformation by focusing on science, technology, on public health, like we have in this event today. So as we all know, universal health coverage, it gives access, gives quality health care to everyone irrespective of their status. So it doesn't, universal health care doesn't limit it to how much you have. But when there is universal health coverage, everyone has access to quality health care. But we know this is far from the reality in Cameroon. In Cameroon, we have so many limitations. First, we do not have the adequate personnel. Next, we do not have the finances to be able to attain that. And with the sustainable development goals, one of the sustainable development goals actually is to achieve universal health care by 2030. Now we are in 2019. How can Cameroon achieve universal health coverage by 2030? So that's why we are here. We are here to propose solutions, to look at those challenges and propose solutions. Let's take, for example, the 2019 budget in Cameroon. We see that healthcare is just about 4.29% of the budget. That's not supposed to be the case. We have to invest more in healthcare to be able to attain universal health coverage. So I'm so glad you all are here on behalf of our founders, Dr. Denis and Lenora, wife Lenora Foretia. We welcome you to this event, and we ask you to make yourselves very comfortable throughout these events. We have our panelists who were here on time. We have Madam Kijachi Alice, and we have Professor Bacham. We have Dr. Ipie Terence. We have Dr. George Boyle. We are so happy to have you amongst us. And we also have you, I won't call you by name, but we have your names registered outside. And we want you to know that this is going to be an interactive session. We want to know what you have to propose, because that is our role as a foundation. That's our role as the Nkafu Policy Institute, to bring together minds like you, to bring together health professionals like you, to propose solutions that will make our country move forward. So thank you so much again for coming, and please do have a wonderful time, and feel free to ask as many questions as you can, and we hope that the event will indeed be a success. Thank you again.
Good morning, friends. Good morning, speakers. Good morning, ladies and gentlemen. We are grateful that you honored our invitation and you came that we can share ideas, we can contribute to knowledge on how Cameroon can achieve universal health coverage by 2030. On the 7th of April 2019, the World Health Organization celebrated the World Health Day on the theme universal health coverage for everyone and for everyone everywhere. And today the Denis and Lenora Foretia Foundation, the Nkafu Policy Institute of this foundation, wants to lift up its voice to contribute to how Cameroon can achieve universal health coverage by 2030. And we invited experts that are going to share their experience, that are going to contribute to knowledge on how we can achieve universal health coverage. In the hall also, we also have contributors who are going to be sharing their knowledge, sharing their experience, and helping us on how we can achieve universal health coverage. Before we get to the panel discussion, I just want to give us this brief background on universal health coverage. Universal health coverage is the #1 goal for the WHO, and as we all know, health is a human right to be enjoyed by everyone, everywhere. It is not a privilege for a few. It is a human right for everyone, no matter who you are. Even the poor mother in the village is supposed to have quality healthcare services without suffering financially. And this UHC, that's Universal Health Coverage, promises a world with access to healthcare services without financial hardship, and nobody should get sick and die because they are poor or the services are far. People should get the services when and where they need it. I borrowed these words from the WHO Director, Dr. Tredos. And reports from the WHO says at least half of the world's population do not have access to healthcare, and 800 million people spend at least 10% of their household budget just to pay for healthcare services. This is to show that out-of-pocket expenditure is really high, and we are here today to see how people can reduce the out-of-pocket expenditure and make their living better. And in 2017, in our context, the President of Cameroon launched the Universal Health Coverage Policy, that's 2017, and in 2018, the Ministry of Public Health, the former Minister Andre Mamafuda, launched the achievement of the first phase for universal health coverage. And today, we just want to find out from our panelists. They're going to enlighten us or drill us or share their knowledge with us on universal health coverage. Thank you, Professor Bacha, for making it here today. We would like to find out from you, from your experience as a professor. You've been working in many organizations. You're the chair for the biotechnology unit of the University of Yaoundé 1. We just would like to find out from you, what do you think universal health coverage is?
We're here, and I think that it's a wonderful thing to bring them together so they'll be part of the entire debate. I also want to acknowledge a little team that I had. We just worked on where Cameroon is in terms of universal health coverage, and the article is about coming out of publication. And so I do acknowledge that whatever contributions I do here is an assembly of what this other team did, and so this is I'll be talking about that. I was happy that the young man who introduced universal health coverage and looked at the global perspectives, kind of did the greater part of the job. And I think it is an initiative that is most welcome. However, there are a number of challenges which I think we have to overcome to ensure that universal health coverage is a reality. And talking about that, I think we have to be very more proactive in how we desire to attain this universal health coverage. And I particularly enjoyed the aspect of trying to achieve that by also pointing out that issues about surgery need to be addressed. And I think it's one of those things that consumes quite a bit of household incomes when it gets to that stage. However, I would be keen in understanding what others have to say in terms of the approach. Currently, I think the entire universal health coverage program is very much on resolving issues of pathogenesis. I would stand arguing on the other side that I think that we need to also encourage very, very strongly on salutogenesis. That's the antipole of pathogenesis, and I can elaborate on that much further. But I think these are my introductory remarks, and I guess when it comes to the challenges where the others don't speak about the things that need to be addressed, I will talk about it.
Thank you very much, Professor. As he rightly said, Cameroon needs to be proactive. The time for action is now. And we'll just move over to Dr. George Bwele, the CNN hero for in 2013, and he's the president of ASCOMBI. And Dr. George, he has been doing a lot of voluntary services in the rural areas, and I'm sure he has a lot to say about universal health coverage. He has tested the pain of the rural community, the pain the rural community they go through in achieving good healthcare services. So, Doc, what do you have to say to us today?
I'm Dr. George Bwele. I'm a surgeon. I was so happy that Dylan introduced the Nkafu presentation, talking about surgery. And I'm working in Yaoundé Central Hospital. When you saw the video, they talk about Yaoundé Central Hospital all the time. When I watch it, I saw my day-to-day work. And every weekend, I set up a small team of volunteers every single weekend between February and mid-December. I want that everyone notice that it's every single weekend between February and mid-December. I set up a small team of volunteers and go to one village and try to reduce people's suffering. And it was a wonderful thing because I decided to talk to you today about hope. As a surgeon, I will not speak a lot. I will just give you some examples. Souvent, quand on arrive dans un village, la plupart des gens qui travaillent dans les villages, ce sont les agriculteurs. Quelle est la maladie de l'agriculteur? L'agriculteur travaille et il a mal au corps. Après le mal de corps, il y a une maladie qu'on appelle la hernie. La hernie, c'est un trou. C'est un trou qui a été fabriqué par le fait qu'il travaille la terre. Et le fait de travailler la terre, ça ouvre ses muscles. Et il a un trou. Et à travers ce trou, l'intestin passe. So sometimes when the patient has hernia like that, with the weak muscles, you have a hole, and you have intestine used that way because of the pressure, abdominal pressure. The man who has a big farm cannot continue to do the same work. He reduces his work. He will not produce more, as Dylan told you. I will not give you the WHO statistics. I will give you mine that I use every day. You have a father who has a big farm, make cocoa, but with the hernia, he will not work anymore. And I just come and tell him, "Papa, don't worry. I will do the hernia for free. And after 2 weeks or 2 months, you can restart your work." That's what we are doing. And per year, we can do something like 1,200 surgery for free. With a small group. Normally, as a governmental worker, they don't allow me to work in a private clinic. But I said this is not a good role, because if I'm a teacher, I can have students that I give mathematics at home and they can give me money for that. And the president himself says that after 3 p.m., we need to work a lot more to make money because we have crisis. So as a doctor, I said, no, I will not stop my work at 3. I can continue in private clinic, make money. When I make money like that, I use that money to finance a surgical program in one Cameroonian village. And per week, I can do something like 30 or 40 surgery, free of charge. And when I stay calm, I say, if as Covim, a small group like that, can do things for free to people, I'm sure Cameroon can do that. It's just to think, it's just the mentality. We have a lot of professors, we have a lot of people who have big knowledges. I'm sure if they give opportunity to those people to take the decision, I'm sure we'll do these things in a few days. We have a lot of resources. You cannot imagine that only me, as COVID member, I can go to MTN. I say, okay, MTN, please treat those population this week. We went to Far North, treat those people for free. And MTN allow me for the medication, 2, 3, or 5 million. Say, buy the medication and do this. And we go together and we do the thing, and we come back. And those people trust on me. I'm sure even if the resources, Cameroon have the resources to take care of people. I listen in introduction, they say they use 4% of our budget for the health. It's not possible. WHO asks 15. It's 15. So this is just the introduction to say that when I go to the bush, sometimes I see people and I make a small deal with the man I meet there. You have an hernia, I do your hernia for free. But the only thing I ask you is to send your kids to the school. Because every time, after that surgery, people say, oh, I'm so happy. I want my kids to be like you. No, it's not true. Your kids cannot be like me. Your kids will be better than me if you send them to school.
Thank you very much, Dr. Josh, for sharing your experience. You have worked with the royal community and you have seen the pain they are going through. And in your own little way, you want to contribute to how these people they can have good quality services. We know surgery is very expensive in Cameroon, and out-of-pocket expenditure, I'm sure people spend a lot. They really spend a lot from their household budgets, and you are offering that for free. We really applaud your services. And as you said, if Cameroon has a lot of resources they can put in place to make sure that they achieve universal health coverage. It's something you started in the rural community, and maybe we can replicate it in other communities. Okay, we'll move over to Dr. Epien. He has been working in the hospitals, and I'm sure he will have something to say about universal health coverage.
As an introduction into the whole issue of universal health coverage, I'll give you an example of an experience I had in 2016 while working in Douala as a clinician. So this evening, I received a lady, I think about 18-year-old, who I just put to bed in Idea, and she was of blood group O rhesus negative. So she went into postpartum hemorrhage, and they had gone all around Idea. They could not have a hospital where they could give her blood group O rhesus negative. It is important for us to know that just about 3% of Cameroonians are of that blood group. So this lady was referred to L'Hôpital La Cantine in Douala, but for fear of, when you call La Cantine, there's some phobia that comes to mind. So she decided, the family decided to transfer her to a different hospital where I was working. While in the hospital that night, I was the only physician on call, and unfortunately for her also, that hospital did not have blood group O rhesus negative blood. So it was a difficult situation. But to me, there was a possibility, there was a hope, because I was of the same blood, I'm of the same blood group like her. So I had to make the tough decision, either to stop work that evening, donate blood to her, or I let her go, not knowing where she was going to get that. So I made the tough decision to donate blood to her that night while working. She was stable the next day, but it dawned on me that if we were to do this on a one-to-one basis, as a blood donor, I can donate blood just 3 to 4 times in a year. How sustainable can that be? So I decided to start up a blood donation foundation, which is called Donate for Life Africa, which simply connects blood users or blood needs and blood banks. That is called Donate for Life app. So the essence is going to increase the drive for blood. So the statistics that shows that maternal mortality in Cameroon could be reduced by 25% if blood was made readily available, and infant mortality could be reduced by 15% if blood was made readily available. So this is just go to support the fact that universal health coverage is something that can reduce maternal and infant mortality within our context, and can also improve productivity within our country. So universal health coverage is something that we must embrace, and it's time for action. Thank you.
Pour ce qui est de la couverture sanitaire, je crois que le Cameroun a reçu l'information comme, comment je vais dire, quelque chose qui va nous permettre d'améliorer les performances de nos programmes de santé. Parce que qui dit couverture sanitaire parle de l'accès de toute la population aux soins, de l'équitabilité dans l'offre des services et surtout recevoir les soins sans toutefois appauvrir la population. Comme disait le modérateur, l'ancien ministre de la Santé publique, avec les autres parties prenantes qui sont généralement le ministère de la Sécurité sociale, ont déjà eu à mettre en place plusieurs informations concernant la couverture sanitaire universelle. Je crois que je suis armée pour répondre à toutes les questions qui seront posées ici en termes de faisabilité, en termes de défis, en termes de perspectives pour la mise en œuvre de la couverture sanitaire au Cameroun. Je suis également contente parce que tout à l'heure, il y a quelques vidéos qui nous ont été présentées. Et vous comprenez à travers ces vidéos que la population souffre, que la qualité des soins que nous avons dans les formations sanitaires ne sont pas meilleures. Et nous pensons tous que la couverture sanitaire universelle viendra répondre à la plupart des thématiques, à la plupart des questionnements que nous avons vus ici.
Do you think it actually reduces poverty? Do you think this strategy actually reduces poverty, or what's your perspective on it?
No, I'm sure I'm not doing something particular. The truth is that at the beginning I was thinking, if I help someone, I change his life. Now I know it's not true. But those people change mine. Because something that I do more than 15 years, every weekend, that means it's important. It's important for me now. With this program, I think it's the time for the government to be happy to bring health services and care to the population. And not only for the population to be happy, but even if the government will be happy about this. Quand je prends l'exemple de mon hôpital là où je travaille, l'hôpital central, par an, l'hôpital central soigne opère 1500 personnes, mais il n'y a pas que les opérations. Je vais vous prendre un exemple simple. Chaque fois que je fais mes campagnes, l'une des consultations les plus puissantes que j'ai vues et les cris les plus performants que j'ai vus, c'est l'ophtalmologie. Les gens se plaignent toujours que j'ai mal aux yeux, je ne vois pas, je ne fais pas comme ça. Et à la fin, la consultation est tellement importante. Chaque fois que je pars dans ces villages, j'ai fait un petit jeu. J'ai créé un petit jeu que j'ai appelé « Aidons les femmes à accoucher à l'hôpital ». ONU Femmes avait un programme pour faire accoucher les femmes à l'hôpital. Et ONU Femmes disait, à chaque matrone qui est dans un village et qui fait accoucher les enfants, on lui dit, si tu amènes la femme qui vient accoucher chez toi à l'hôpital, on te donne 8 000. Et maintenant, les femmes qui font les accouchements à la maison, dès que tu venais vers elles, on t'amenait à l'hôpital et on donnait 8 000 à la personne. Moi, j'ai créé un autre contexte qui consiste à dire à la femme qui est enceinte, viens accoucher à l'hôpital. Quand tu vas accoucher à l'hôpital, parce que je sais que tu vas accoucher à l'hôpital, je te donne la tenue que ton bébé va porter le jour de l'accouchement. Je te donne tout le matériel de toilette que ta femme va accoucher, que ton bébé va utiliser quand tu vas l'accoucher. La première fois que j'ai fait ça, j'ai offert ça à 32 femmes. Et j'étais dans un village qu'on appelle Ndjola. Ndjola, c'est à Gong. Gong, c'est proche de Garoua. J'ai vu un homme fâché. Quand on a donné les 30 femmes, un homme s'est fâché. Il est parti vers le village et il est revenu en grondant. Et une femme enceinte était devant lui. Et il dit, tu es là, tu dors. On est en train de distribuer les habits là-bas pour les bébés. Après, tu vas venir m'emmerder. Avance. J'ai donc compris que ces gens ont le principal problème, c'est la pauvreté. Il y a la pauvreté, on ne va pas se nier. Même les enseignants camerounais qui gagnent 200 000 francs, dès que leur enfant naît à la maternité de l'hôpital central, on lui dit que cet enfant-là a l'infection. Il faut l'antibiotique, 10 000 francs par jour. Au bout du 4e jour, il va commencer à appeler les cousins, les oncles et tout. C'est ce que la couverture santé universelle va venir effacer. Et moi, j'ai foi en cette couverture santé universelle. Je pense que c'est réalisable. Je pense que si nous tous nous mettons d'accord, on va faire beaucoup de choses. Et je vis tellement d'exemples avec ça. Tellement. Parce qu'aujourd'hui, on va me dire, tu vas acheter les habits pour tous les bébés du Cameroun, mais je vais acheter autant que je peux. Si ça peut amener une femme à accoucher à l'hôpital. Et je sais que le relais sera apporté bientôt avec la couverture santé universelle. Je vous remercie.
Merci, Doc. Prof, let's just hear from you. Do you think it actually reduces poverty? Because WHO actually says universal health coverage reduces poverty because it reduces out-of-pocket expenditure. What do you think, Doc?
Poverty is not the lack of money. I think it's a construct which we're enslaved in, and it just drives us down the line, and we end up believing that we are poor. I think you just had the personal testimony of George, and that's a clear demonstration that even when you have very little, you can share. Why do I say poverty is not the lack of money? Because most of us would think that it's poverty when you're poor, it's when you lack money. And no, I think that we can do much better. We can finance it. And I think I would take another forum to explain to you what also led me to being like Terence and George. I also run a foundation since 1998, just a kilometer from you here, at Mount Edis, the Foban Foundation. And we've been trying also to promote this idea that poverty is not the lack of money. And having said that, I think I have one major difficulty. Of course, when you have to assist people with surgical procedures, when you have to assist them with how they obtain health, that puts money in their pocket. Now it's up to them to know exactly how that money can be used for other gainful purposes, and that's, I think, where we need to do the deconstruct and then encourage people into better health. I spoke earlier on about salutogenesis, and this is about disease, or it's about health. When you say disease, then it's pathogenesis. When you say health, then it's salutogenesis. And it's about how we promote and how we prevent and how we encourage people who are in good health to stay healthy. And there are a number of things, even before we get to the surgical procedure. I do not know whether George has a program for understanding why the different populations ended up having hernia. And you talk about hernia. We also, on the biochemical side, because my background is in biochemistry, we know that stress levels engender a number of chemicals that spill out into the body, and those can weaken the muscles. But I'd like to know from you or link up with you to find out exactly why those hernias happen in some people and not others. But by and large, just to come back to your question, I think that we need to put into the minds of the population, and I think you need to step up your campaign in how we attain universal coverage, that people can actually pay for it. People can make contributions to pay for it. It's not always the government. I have followed up the government. As I told you, we just wrote an article of an appraisal, and the contributions from the population towards universal health coverage is 1% of what is needed to pay for universal health coverage. So where is the rest of the money going to come from? And I think that we can pay for it in various ways. You know about the Grameen Bank initiative. Based on that principle, that idea, we also seeded something similar, but it's just to get the rural population, especially those that are farmers, to work for their health. And whatever they make as produce, we set aside, and then they can take the rest and sell for whatever purposes. But just $10 a year should be able to afford for their health. And those who are richer in the communities in which they are should be able to contribute for the health of others. Because if it's going to rain, the rain doesn't choose one rooftop. It rains on every rooftop.
Thank you very much, Prof. My Prof said poverty is not just the lack of money. It's not just the lack of money. That's it. And WHO says it reduces poverty, but Financial hardship, though, do you think it's in line, maybe WHO was going to say maybe financial hardship, not just poverty? Do you think so, though?
Well, I think, if you look at the WHO definition for health, it says the physical, mental, and financial. So it takes all these aspects. And it's an intricate web of many factors that play in this particular equation. I don't know how to define hardship, and I don't want to believe that hardship is what we have promoted on the media to mean. And if you look at, I'll just give you an example of, I experience a lot of hardship. Hardship not because I lack the resources to fund myself. Hardship because I'm now subjected to a number of health conditions which I shouldn't have been because I am not in a rural setting or I'm not a peasant. For example, all types of metabolic diseases are setting in. I get in the morning, I get into my car, there's no exercise I've done, I go to the office, I sit down, I come back, I eat, I watch television, I fall asleep, and the next morning I continue the same routine. My grandmother walked 7 kilometers to the farm. That's exercise. She holds the whole day. That's exercise. And she walks back 7 kilometers, cooks, and then sleeps. And the next day, and you wonder why she got to 90-something years old. And I experienced a health hardship, which is not financial, which some of the people in the rural population enjoy.
Thank you very much, Prof, for sharing your experience with us. And I'll go back to you, Dr. Apia Terence. Do you think the vulnerable are included in universal health coverage? Because you say you're working with the mothers, you're working with the children. Do you think universal health coverage can actually help mothers and children have quality access to health care without suffering financially?
Thank you for that question, and I want to cue in with the previous question. I think my answer will answer, but if you look at the World Bank Early Development Program, you will discover that it says if we are able to provide quality health care to mothers during the period of delivery, those pregnancy and delivery, then the first 5 years of life, that's early childhood life, you discover that productivity overall in the nation is going to be optimal. What does that mean? It means that if that context is not put in place, it means that definitely we are building on an unhealthy future generation, which means they will be unable to create wealth, they will be unable to maintain what has already been created. So indirectly, it's going to contribute to reducing overall national growth, it's going to contribute to reducing productivity within the nation, and it's going to make the nation poorer.
Just share with us your experience. Do you think it's attainable in Cameroon?
Yes, I think. I have a lot of hope. I was in Mesamena. I don't know if you know Mesamena, but Mesamena is not so far, it's in the east. Yeah, I was doing a medical mission, and during the medical mission, I have something like 1,000 people, and I spoke to people, say how we do this, we do that, and there was someone around me, and the man said, "You will also treat me today. You will also treat me today," and all the people started shouting against him, "Go to the other side, go there." And when I meet the guy, I discussed with him. He was a man, 47-year-old, and when he was born, he lost his mother during the delivery, and 3 years after, he lost his father. But the guy was born with an hernia. So you can notice that the man was 47 years old, and he was having 47 years of hernia. So you can imagine now why this hernia was. The intestine was inside the knee, like that. So when he eats, the food cannot go straight into the colon as all of us. No, he goes straight to the knee and then come back. So he stays something like 2 months without going to school. So that was so long, 47 years. And the stool itself make a small hole here to go down. They call it fistula. So the man come to me and say, look at me. And you know, in the village, this kind of man is like witchcraft or something like that. So that's why people stay, told me, go to the other side, go to the other side. And I saw the man, 47 years old. 47 years of age. And I told him I'll bring him to Yaoundé to do the surgery. And we came here in Yaoundé. It took 2 hours for me to do that. 2 hours. And before the end of the surgery, the man started telling me, Doctor, are you finished? Doctor, are you finished? Doctor, are you finished? I say, yes, I finished. And the man looked at this side, the left and the right, and looked at one nurse and said, you'll be my wife. At that time I stopped, and it's that time that I understood the real problem of the man. 47 years of the frustration, 47 years of Enya, 47 years without a woman, 47 years without nothing. Yeah. And after that surgery, the man told me, I will start to work at each time. He said, after 2 months. A year after, I saw the man, big farm, 2 wives, 3 So, and I was so sad because it was only 2 hours for me to arrange that. And now the guy has a farm, the guy make money, and he has a family. So these are kind of things make me think that, did you listen to the professor? They give a lot of the issues that if we succeed to ameliorate those issues, we will have a better life. So I think I trust on this, and that's why I'm running a religion. Because you look, there are some few things. I mean, in one village in Gato, the same place, after Ikaduma, met someone, 31 years old. 31 years old, he told me, okay, doctor, I want you to listen to me. I want you to listen to me. I'm married since 2 years. I said, okay, you are married since 2 years. What's the problem? I'm married since 2 years. I have my wife, but we don't have any sexual relation. I said, okay, I'm sorry, me, I'm not married. But I know if you're married, you need to stay with your wife and stay with her. So the man told me, no, my wife was born with something at the interest of the vagina. And examined the wife. And there was something, she was born with it. The wife was 24 years old. And you see this kind of couple, take the wife, 40 minutes after, we remove the mass. And now the guy said, I have 2 or 3 kids. We are happy. And I said, 40 minutes I'm sure with equity, with bringing equality, with everything like that, we will bring a lot of professionals. It will not be easy. It will not change tomorrow. It will take time. But we have a lot of professionals. I just pray that they give opportunity to those professionals to speak and apply what they know. Because Prof told you, it's not the problem of doctor. It's the problem of all of us to bring ideas and to apply. We need to learn. There are new things that we have to use. If you go to US, I went to US to discuss with people there. There are some people who pay the ENYA 1,000 and there are other people who pay the ENYA 10,000 because of the resources that they have. So all of us, we have to contribute. Even if you don't have money, they can ask you to pay 100 for something, and that you have. And this is your contribution, and you are happy to give that. So I think for me, this I thank the foundation for this. And I pray that if we trust to our professional, we'll have a better life. I'm sorry because I have a lot of emergency. Listen, my phone ringing. It's because of emergency in the hospital. So I'm sorry, I will go. Sorry.
We are very happy to be here today, and a lot of us have learned from your experience. As Professor said, it is universal health coverage is. it's an intervention for all of us to put our resources together. It's not just to wait on the government and say, okay, government finance our healthcare services, but for us to volunteer, put whatever we have. Let's not say we don't have money, but even our resources, our human capital, and so on. Thank you very much, Dr.
Thank you. Thank you. Thank you, panelists. It was my honor.
And I think the essence is to fine-tune whatever ideas we have, and no idea is too small. I know one of the key challenges that many people may talk about is the financial contribution. If you look at how much it's going to cost the Cameroon government to be able to put such a system in place. But as Prof said, with everybody contributing by compulsory subscription, it makes it easier. And also looking at the corporate social responsibility, we have many companies in Cameroon who are making millions in dollars in profits. They also have a place in able to help Cameroon achieve the universal health coverage. And one other key thing that will come along with universal health coverage is we have improvement in the structural, in the nature of healthcare, because our health centers are going to be capacitated, our regional hospitals, our district hospitals are going to be capacitated to be able to meet up to the standard. Because when you look at the strategic document on the universal health coverage, there is a process of accreditation. And this process of accreditation simply means that there is a minimum standard that any facility which is subscribed to the universal health coverage plan has to attain. And for this to happen, it means that there must be some money that will come into developing this infrastructure. And it will make it easy for someone like Dr. George, who probably before used to go to far places. Now those facilities or those regions will be able to be capacitated to be able to take care of their own health care. Those are some of the advantages that come with the universal health coverage. And also, to add, for us to kick off universal health coverage, let's talk about big data. Electronic medical record is something that we can't run away from it. If there is no electronic medical record in the system before they take up a universal health coverage, then we are chasing the wind. Because when you look at the procedures that go around other processes, for example, in Cameroon, we discover that people are challenging the system in fraud. So universal health coverage, the money that will be lost in universal health coverage will be more than the cost in putting in place an electronic medical record. So I remember during one of the sessions we had on universal health coverage, it was one of the key things that was raised. That if electronic medical records do not see the limelight, then we are wasting time. Because fraud is going to wreck the system. And one key thing about universal health coverage is sustainability. In the US, we talk about Obamacare and all of that. People are saying that it's not sustainable and all of that. But any universal health coverage, wherever in the world, has to be sustainable for it to be able to meet the needs of the nation. So if we put in place a system that is not sustainable, then it means that as the years are going, we're just planning to fail as the years are going. So those are some of the key things that I think I could have addressed to what the other panelists have said.
Thank you very much, Dr. Eke. We talk about big data and sustainability, because if we want to attain universal health coverage, it's not just for the year 2030, but even after 2030. So dear panelists, we just like to hear one last word, like the policy description, or what you can tell the government of Cameroon, one last word before we move over to the participants again have questions and questions for contributions.
Je crois qu'il est important qu'on renforce le plateau technique, que le paquet minimum d'activité dans les formations sanitaires, selon le niveau de notre pyramide sanitaire, que ce soit égal parce qu'on parle d'égalité. Il y a également le problème de médicaments. Je pense que les formations sanitaires doivent disposer des médicaments au sein de la structure sanitaire. Je vais revenir sur quelque chose. N'oublions pas, au Cameroun, on est passé à l'échelle avec le concept IBF, Persona Based Financing. Je crois que c'est un élément important pour la pérennisation de la couverture sanitaire au Cameroun. Ça va se passer comment? Parce qu'il est important. Point de but, toutes les formations sanitaires ne vont pas faire partie prenant de la couverture sanitaire universelle, sauf les formations sanitaires qui auront rempli les critères de choix, seront affiliées à la couverture sanitaire universelle. C'est pour ça qu'aujourd'hui, avec le PBF, Performance Based Financing, qui est un concept, on ne laisse plus l'argent au niveau de la trésorerie. Parce que l'argent qui entre dans la formation sanitaire, vous les utilisez pour améliorer votre plateau technique et améliorer le paquet d'activités de votre formation sanitaire. Donc le PBF, c'est un élément important qui va nous permettre de pérenniser la couverture sanitaire universelle. Je vais continuer en disant que je ne dois pas être pessimiste, je reviens sur ça. Prenons le cas du VIH-Sida. Souvenez-vous, avant pour mettre quelqu'un sur traitement, on devait regarder le taux de CD4. Lorsque l'Organisation mondiale de la santé est arrivée avec les nouvelles directives test-centriques, au Cameroun, on a des ruptures en test. Mais nous ne sommes pas restés derrière. On a dit, bon, mais si on a des petits pays qui ont accepté, pourquoi pas? On est passé au test-centrique. CBCH, aujourd'hui nous avons des résultats, vrai ou faux? Aujourd'hui nous avons des résultats et nous pouvons atteindre l'objectif 90-90 dans quelques mois. Et pourquoi pas éliminer le VIH ici 2030? Donc ne soyons pas pessimistes, donc je pense que nous pouvons. L'autre chose que le gouvernement, parce que le gouvernement doit être garant de la couverture sanitaire. Parce que le véritable problème ici, c'est que ceux qui ne travaillent pas, il y a des gens qui vont payer pour ceux qui ne travaillent pas. Et le montant alloué par rapport à la couverture sanitaire sera, comment je vais dire ça, équivalent à ce que vous gagnez. Ce sera difficile d'identifier les personnes vulnérables. Qui est personne vulnérable? Ça, c'est un gros défi pour le gouvernement camerounais. Il va falloir qu'on élabore le projet de loi qui va rembourser les formations sanitaires, parce que c'est pour venir à la formation sanitaire, on vous offre les soins gratuits, mais à un moment donné, on a besoin que ce financement soit remboursé à la formation sanitaire. Donc je crois que ce sont des éléments importants. L'autre défi, c'est le respect du timing. Parce que lorsqu'on regarde les phases, on dit de 2020 à 2025, on doit faire ceci, mais l'autre chose que je vous dis, c'est que la couverture sanitaire universelle va venir répondre à... Je prends l'exemple de la vente illicite des médicaments. C'est un gros problème de santé publique au Cameroun. Mais si on a la couverture sanitaire universelle au Cameroun, les gens ne vont plus aller à Mokolo ou bien dans d'autres... aller pour s'approvisionner. Parce que si vous êtes malade, est-ce que vous savez que vous allez être pris en charge gratuitement? Vous irez à la formation sanitaire. Ça va réduire le nombre de nos patients que nous perdons de vue, qui sont dans les églises, qui sont chez les praticiens. Donc je pense que oui, pour la couverture sanitaire, nous devons travailler ensemble. Nous devons travailler, toutes les parties prenantes doivent travailler ensemble pour que la couverture sanitaire soit implantée au Cameroun.
Thank you very much, Madame. Professor?
I will just go back to my last word would have to be on how to fund this universal health coverage. One of the principles of the coverage thing in Cameroon says that everybody should be able to pay according to their capacity, meaning that if I earn more, I should pay more. That's fair, it's a pay system, pay as you earn. And I think that we need to pay more. Now, the richer guys have more phone calls every day than the poorer guys, yeah? But do you know how many phone calls Cameroon makes a day? 17 million. 17 million calls. If we tax every call, 1 franc, I don't want 10 francs, 1 franc for every call, the telecom company from this whole universal health coverage without even blinking. 17 million francs every day, for 10 days, for 20 days, for 365 days, you fund your universal health coverage without even asking me again to pay. So I'm paying as I earn, because the richer I am, the more calls I'll make, yeah? Without having to run into WhatsApp and give free calls. But, there's 17 million calls made in Cameroon every day. Look at the statistics. Now, if you tax 1 franc per call, you cover your universal health coverage. So the debate, unfortunately, I'm not at that ministry meeting, but I hope that you will take my concerns. That let's tax the telecom companies, let them pay for this thing. And it's possible.
Thank you very much, Doctor.
Maybe I would like to add something. In addition to what folk have said, there are many other companies. We have des aéroports du Cameroun, we have Dangote, we have toutes les compagnies qui emploient les Camerounais peuvent payer pour la couverture sanitaire universelle. Ça, vraiment, il faut le dire. Mais il y a un problème, parce que de l'autre côté, on a le prix du pétrole qui a baissé, on a le prix des aliments qui ont augmenté, et ils ne sont pas prêts. Je ne sais pas si vous comprenez, à financer beaucoup d'argent pour la couverture sanitaire. Mais quand on dit le groupe, on peut le faire.
Well, thank you very much, Prof, because you brought out a very strong statistics on telephone networks and how they can finance healthcare. I think that's a strategy the government can put in place to make sure that we finance healthcare.
Je suis Ouvon Lozoa, Alain Thierry. Je ne suis pas du corps médical. Je suis plutôt géographe, chercheur au ministère de la Recherche scientifique et au centre de l'éducation. La couverture santé universelle, ce n'est pas seulement une question du corps médical, ça concerne tout. Et c'est pour ça que je me propose de dire un mot dessus. Pour commencer, je voudrais d'abord remercier la Fondation pour m'avoir invité à cette conférence. Je pense que concernant la couverture santé universelle, la première des choses, il y a plusieurs choses que je vais dire, mais la première des choses que je vais dire, c'est d'abord sur la communication. La communication, pourquoi? Parce que comme tout ce qu'on fait au Cameroun, c'est souvent mystérieux. Et c'est après, à la fin, on sort, au 17h, on dit qu'il y a un texte qui a dit comme ça, qui a dit comme ça. La couverture santé universelle concerne les hommes. Et pour qu'elle puisse réussir, il faut qu'on puisse faire comprendre aux populations que ça les concerne directement, c'est pour leur bien-être. Et ça pourrait aider à financer. Je prends le cas par exemple de la CNPS. Il y a quelques années, la CNPS a sorti, je peux dire, un allègement qui permet aux non-travailleurs de l'État de pouvoir souscrire, de cotiser par jour 300, 200 francs et pouvoir, à la fin, pouvoir avoir une pension, pouvoir souscrire. Je pense que si on commence à faire du porte-à-porte, à expliquer aux gens, que ce soit en ville, et d'ailleurs en ville même c'est plus facile, mais plutôt dans les campagnes, expliquer, il y a des agriculteurs comme le docteur disait là, qui ont de l'argent, qui peuvent se payer, que ce soit les cartes de santé, que ce soit les cartes, qui peuvent payer à toute leur famille, mais qui ne savent pas. Donc je pense que Madame du ministère de la Santé, allez-y demander de faire une meilleure communication dessus. Parce que c'est bien de venir, nous on a la chance de venir dans une conférence comme ça et de vous suivre. Mais il y a beaucoup qui ne savent pas ce que c'est. Et s'ils savent ce que c'est, ça va pouvoir aider le financement de cela. La deuxième chose, c'est quoi? C'est que chez nous, en géographie et développement, parce que je suis dans le développement, on dit que le développement ne se décrète pas. Il se fait sur la base des ressources naturelles et humaines propres à chaque communauté. Ça veut dire quoi? Ça veut dire que, comme on a parlé de santé universelle aux États-Unis, on a parlé en France, on parle partout, et puis on vient au Cameroun, on dit santé universelle. Déjà, je suis d'accord avec le prof, il faut changer de nom. Santé universelle, peut-être encore, pour moi, couverture santé pour tous. Ça pourra permettre de ou alors santé nationale. Ça pourrait permettre, parce que universel, vraiment, ça reste un concept calqué européen, on vient le mettre chez nous directement. Maintenant, pourquoi ça puisse réussir, comme je disais tout à l'heure, il faut qu'on puisse réfléchir à un modèle camerounais. Ne pas prendre toujours comme ça vient ailleurs et venir calquer chez nous. Ça a toujours échoué, c'est peut-être qu'on a fait ça. Et maintenant, retirer l'État comme partenaire financier. L'État peut être superviseur général, mais pas partenaire financier. Pourquoi? Parce que l'État n'a plus d'argent. Que ce soit en 2020, 2025, on ne pourra pas atteindre. Si l'État, c'est l'État qui gère, on ne pourra pas atteindre cela. Pourquoi? Parce que chaque jour, les crises naissent. Nous, on est au ministère de la Recherche, là-bas, on n'a pas d'argent parce qu'on dit que les finances n'ont pas d'argent pour pouvoir signer, que ce soit les missions, n'importe quoi, il n'y a pas. Donc, je ne pense pas que l'État ne doit pas financer cela. Ni même les partenaires au développement. Pourquoi? Parce que avec les partenaires au développement, c'est très simple. Le jour où l'État fait une bêtise, par exemple sur le droit de l'homme, comme on a plus d'éléments là, Donald Trump peut décider de fermer les banques, on ne donne plus d'argent au Cameroun pour pouvoir financer les choses, et c'est fini, on meurt là. Donc il faut être indépendant sur cette couverture santé. Pourquoi? Parce que ça concerne les Camerounais.
I don't know the problem that we really have in Cameroon. Because the first question we need to ask ourselves, do we really need a universal health coverage system? Or call it comprehensive? I'm sure all of us will say yes. I believe in that, yes. But now, what is the problem? Why is it that we can't get this thing working? I've not seen anywhere in the world where the private people are the one implementing universal health coverage. The private groups or organizations or any other person is just supporting what is going on. And the government should be able to set up the platform for this to be implemented. And if there are discussions to lead to the point of, funding, the various organizations are there. Private organizations will talk about, probably talk about MTN or talk about the communication companies or other companies like Dangote. You can get funding from all these people if you can't do it yourself. But I don't think any private organization will be able to start that comprehensive healthcare in this country. It doesn't work anywhere. I've not seen it. I've been in places where they have good health coverage, where the people themselves pay very little and they get a lot from it. So I think our problem should be this, which they should be looking at. Those are the ministry. There's lack of political will. That's the first thing. That's the first thing we have to know.
The representative of the Ministry of Health just said many little countries, younger countries in Africa, especially in Central Africa, have been able to go through this. Then why can't we do this? So I think the main problem is some people, top government officials, don't want to, let's say, leave their luxurious cars for little cars so that this can go through. I think that's the main issue. Yes, because I was glad with the Prime Ministerial decree. I think it came out a couple of days ago, restricting some top government officials to travel out for certain unnecessary seminars. I think that's a good step. And how the Ministry of Health sanctioned the medical director of the Edo District Hospital, because we need quality in order to go through this. So I think that's the vital point in this. If other younger African countries, which we know, and we all know Cameroon is better than them, has gone through this, then I think we can do better. I think the problem is just the will, as the doctor said. The problem is the will. And I'm advising that the state should join organizations who are working on this. I think I have a name here. Okay, the Joint Lending Network for UHC. It's an organization made up of many developing countries working on the universal health coverage issue based on in their countries, trying to look at fight and see how they can solve the various problems they face in order to achieve this. So I think that's my own part of the contribution.
On the geographer who spoke about the fact that he's a geographer, I say it's a wonderful thing. Why? Because we need geographic information systems. Currently, I have a biostatistician who is not a geographer, but he had to play the role of a geographer and just show me between 1996 and 2016 what has been the changing landscape of malaria incidents. And he did that on the map of Cameroon, and you could see the colors change, over time. That visual display is what our politicians need. Why? Because they can't get into the figures to understand, but when you show them that it started as green, and it's slowly converting into red, they immediately pick up the picture. So that kind of information, we needed to reduce it at the geography level for people to make a good palpation of what they're seeing. And we need that for most of the stuff. If you tell me on all the diseases that have to be covered, and there are about 10 that Cameroon has listed to start off with, you should tell me the situation of these in all the areas. And I should be able to see that visually without looking at the statistics and data. Just show me by color change in the different regions, then I will know that I can relate to it easily. So we need you people in that. So yes, Cameroon needs its own model. Yes, I agree that Cameroon needs its own model, but that model could be guided by what have been the mistakes of the other countries. And let me just tell you, because I wrote an article which just came out on what Cameroon has done, and it is commendable. But there are still issues that they need to address. Cameroon started off by having a situational analysis. By having a situational analysis, so they've looked at the entire health area sector, and they've seen exactly where we are in terms of risk protection and all of that. So they mapped, they know how much we spend, they know how many beneficiaries come out of insurances and people, or how much the CNPS covers, and all of that. So they've done that situational analysis. Now they've developed the 4 guiding principles, which I talked about: universality, national solidarity, general responsibility of the state. Doesn't exclude private funding, but it says the state needs to step up and coordinate, and then the mandatory affiliation. The next thing is that they developed what they call the healthcare architecture, and to say that, you know, who are the different people who can help do this. And that's where I had a difficulty, and I said we need to federate and have other players. Then they've also developed the universal healthcare benefit package, which talks about what will be done in stage 1 and stage 2, and what the 183 medical conditions that were retained: 48 for children, 25 for pregnant women, 73 for mother and child, and the rest 47 for the entire population. So they have that done. They've also developed the treatment protocols for the benefit package. Yeah, so there's a lot of work. So it didn't start today. They started a long time ago, and they built on experience. They've also done the costing of the universal treatment package. That's the meeting, because that's the weakest part of the current document. That's why they're meeting. I told you they're still using some old figures, 1987 figures. Now they're meeting in the ministry trying to find out what the true figures are, and they've assembled the health economists around the country to be able to do that. Now, the different diseases that for the 183 interventions, they're going to focus on internal medicine, pediatrics, gynecology, surgery, ophthalmology, stomatology, vaccination, otorhinolaryngology, and community health. So basically, these are the areas. Then they've also developed the universal, the matriculation system. How will people be documented in terms of the numbers that they have? Again, I had a problem with the number. It's telling me that I can only have as my maximum 10,000 people per county, but I could have more than that, in which case they've also determined the contributive capacity of the population and the startup of the benefit package. That's why I said, for all that we contribute, we're just 1% of what the whole coverage will need to take. So some other people need to step up, which is why I was suggesting, besides corporate social responsibility, that we should tag luxury, and that's telephony. Yeah? So that's, and they've also classified different contributions, which I think has a problem, but we will wait to see exactly as inactive population, so they don't do anything, the informal agricultural sector, informal non-agricultural sector, employees of the formal private sector, employees of the public and para-public sectors. So they've classified this. It goes from 38, which I think should be less for the inactive population, to $110, okay? And then, so basically, you can see that a lot has been done, and of course there are challenges, and this is where we need to come in. So I hope the minutes from here, or some rejoinder mail, needs to go to the ministry to let them know there has been a discourse, and that there are certain things that have been suggested. You need to accompany them, and the laudable efforts of people who do privately should be coalesced into something substantive and more meaningful. If I look at his efforts, and I look at Dr. Boyle's efforts, I think that we can look for a way in which we actually hone this in and make it become something that is comprehensive for the state of Cameroon, and that will give our own identity. There are certain things that can be improved upon. If we look at what Rwanda has done, if we look at what Gabon has, if we look at what Zambia has, and I think that we've started from somewhere. I think after the meeting of today, we'll go past the 50% mark, and I think we're making enormous progress. But the other part that has to be completed would have to come from the pragmatism of Cameroonians in executing this. And this is where we have the greatest difficulty. Cameroon has the best documentations, best policies, it has the brains, best strategies. When it comes down to the implementation, we have a major difficulty in how it is implemented. Not that we do not know. We exactly know what has to be done. But the right people are not being called to the table, and there's a lot of swindling of public funds to the point where we start to lack even to pay for medications that are supposed to be free. And again, this is something, I don't know. We will just have to keep on shouting until someday, somewhere, somebody listens.
Thank you very much, Professor, for reacting to the questions and to the contributions. Any other question you would like to? Oh, it's a comment.
Okay, thank you, Professor, for those answers. I hope most of the questions of participants are already answered. But in addition of what you said, je voudrais juste dire par rapport au modèle camerounais, il y a beaucoup de travail qui a déjà été fait. Vous voyez, il y a une analyse situationnelle qui a été faite. En termes d'intervention, les interventions que nous avons définies ne sont pas les interventions que les autres pays ont définies. Nous sommes partis sur la base de la prévalence des maladies les plus élevées que nous avons au Cameroun pour identifier nos prévalences. Donc il y a le travail qui a été fait. Il y a également le problème il y a un autre problème par rapport à la gestion de la couverture sanitaire par l'État. Je voudrais vous dire que ce n'est pas l'État qui va gérer parce que le next step, c'est de mettre en place, il est question de mettre en place un comité qui va gérer la couverture sanitaire universelle. Parce que si on parle de couverture sanitaire universelle, on a plusieurs parties prenantes. Mais ceux qui portent ce projet, c'est le ministère de la Santé et c'est le ministère du Travail et de la Sécurité sociale. Bon, maintenant, à côté, on a d'autres parties prenantes. Donc, c'est important. Il y a une question sur le fait que le ministère ne croit pas en ce projet. Je dis non. Le ministère croit en ce projet. Et c'est ça qui explique, parce que nous sommes déjà presque nous sommes à la fin, je voudrais dire, de la deuxième phase. Donc, dire que le ministère ne croit pas à ce projet, pour moi, je ne suis pas d'accord. Autre chose, c'est... Quelqu'un a parlé du privé. Quelqu'un a parlé du privé. Pourquoi est-ce que c'est le privé qui doit porter la couverture sanitaire universelle? Pourquoi nous avons besoin du financement qui vient du privé? Je crois que le prof a lu l'article qui a été déjà publié. Les financements, les sources de financement, autant pour moi, sont bien définies. Ça veut dire quoi? On a des fonctionnaires, on a des personnes qui sont en retraite, on a des inactifs, on a des personnes qui travaillent dans le secteur informel. Et ce montant sera prélevé en fonction de ce que gagne chaque personne dans notre gouvernement. Donc c'est très bien ficelé. Les privés, notamment les sociétés brassicoles, Camtel, ils vont beaucoup payer pour des personnes qui sont vulnérables. Est-ce que vous comprenez? C'est en ce moment qu'ils doivent agir, donc c'est important. Merci.
I think it's the most essential part of it, because if there is no funding, then I don't see a way we're going to move forward with this. And then one thing people have to understand is health is and will never be free. Because you need money to get to pay the people working in the hospitals that give you your health care. You need money to get equipment to run the hospital. You need money to get reagents to run the laboratory, etc., etc. So health will never be free. In other words, for us to get a universal health coverage, people should be willing to pay for it. The essence of it is to reduce out-of-pocket expenditure when you're sick. And most other countries that have gone ahead to try to implement the project have done so by encouraging prepayment methods, by making mandatory health insurance contributions. So I'm excited about the fact that they've taken that into consideration. But if we have to implement this thing, we also have to be able to gain from the experience of other countries in positions like Cameroon. Other African countries have gone ahead to start the project. So we have to look, how far have they gone? What are the challenges they have? Where did they fail? What could we do so we don't find ourselves failing in those kind of areas? I think an example, in countries like Nigeria and Ghana, for example, one of the main challenges they faced with regards to financing was the fact that the poor and vulnerable found themselves dropping out of those mandatory contributions because they couldn't afford for it. So when planning those contributions, when planning to make those contributions mandatory, what happens to those people who cannot afford? Who is going to pay in for them? Another example is that of Thailand. I think Thailand is one of those middle-income countries who's gone the furthest in terms of universal health coverage. About 40% of the population is covered. Initially, they started by funding the project through tax funds, like Prof said, you could tax on telecommunication companies and other things to get money. and then they made contributions by individuals mandatory. And they realized along the line that so many of those individuals, the poor ones, were dropping out of those contributions because they could not afford it, no matter how small they initially thought it was. So at the end of the day, they had to change that policy to have the government finance for those poor and vulnerable. So I hope that when the funding part of the process is being thought of, there is a consideration to the fact that some people may still not be able to contribute for those packages, and so we might have to look for a solution where other individuals or other people will have to fund for those extremely poor and vulnerable, especially given the fact that they are the ones most affected by the inequality in healthcare which we face right now. That was the first thing. And now the question is, the Sustainable Development Goals set by the WHO, the plan is to have universal health coverage up and running in all of its member state countries by 2030, I think so. So my question is this: do we think that by 2030 in Cameroon, universal health coverage will be a reality? If yes, how far gone are we going to be? Nigeria started this project many years back, more than 10 years ago, and so far just 4% of the country is covered, which is almost nothing. So, yes, so my question, we have to learn from the experiences of other people. Before Thailand could get to where they are right now, it took them 24 years to get 40% of the country covered. They're not even up to half yet. So, is it going to be a reality by 2030? And when we say it's a reality, I want to believe that when we say it's a reality, it should not just cover just a small minority of the population. At the end of the day, do the people that really matter, the people that really suffer from inequality in healthcare, that is the poor and vulnerable, those in the rural localities, will they, how far gone, how far covered will they be in the project by 2030?
Thank you, Doc, for that contribution. I think from all the discussion we've had today, you will bear with me that we see it being possible. And one thing that may be lacking is the political will to be able to set it running. If today we want this thing to go operational next year, with everything that has been done, I think it's possible. And there is never anything that can be achieved meaningfully without challenges. It's true, Cameroon is unique. It's true, other countries have been able to try, and they have taken them 24 years, they have taken some 15. But the other countries also, like Rwanda, who make dramatic improvement, and I think now they have up to 90% coverage. So it is possible. I think in different models of governance in Africa now, Rwanda stands out clear. And one thing that has pulled Rwanda in everything they are doing is a political will. So 10 years from now is very long for us if we want universal health coverage. But in terms of project planning, you have to be realistic, putting all other factors in place. So I think in 10 years' time, it is possible for us to have universal health coverage. I think probably the other panelists could have something to say.
Okay, I think by 2030 we'll achieve universal health coverage. That's what you're saying.
Yeah.
That's why we are organizing seminars, forums like this to discuss.
Achieve like the whole population covered.
That's why we are organizing forums like this to discuss the challenges and look for a way forward. Professor?
Yeah. No, I think we can attain universal coverage in the next 10 years. There's phase 0, 2 years. Phase 1, 5 years, phase 2, 5 years. So we're getting there. And if you see what is happening, again, the only way, in my opinion, for us to accelerate the process is to have an appropriate and an adequate communication strategy. People need to be informed, they need to know, we have to be transparent. You have to keep on talking and talking and talking until finally it becomes like a sing-song. You have to invent songs. One of the ways they taught us hygiene lessons in my youth was that they made songs about those things and we sang them, and that's how we could remember exactly what to do in different situations. Those kinds of very simple, low-cost, high-impact activities need to develop. We need to develop I don't hear very much about the communication strategy in universal health coverage. Everybody's doing it is very technical. Our attempt even to write an article to assess where Cameroon is was a way of using it as the platform. The article hasn't come out, it's coming out next week. But Voritia called me to say, hey, you need to talk about this thing. I had to ask permission from the other co-people, saying, I'm going to talk about this. Say, yeah, use the article to say. So it's from there that I have this information of gathering all that they have done. And we'll give it to the ministry. This is what you seem to have done, so that they know exactly where they're going. And again, it is not, okay, the ministry has said, we have to take up the challenge ourselves and ask, what can we, in our own little corners, do to have the process done? It is when we all have made these contributions, or are making these different contributions, that you would finally realize that, you know, the critical mass for people speaking the same language is being attained. And with that critical mass, a lot of things would happen. Again, we have to be very pragmatic. My professor passed here when I was still in graduate school, 10 years, and went through Thailand, and says, wow, Africa, you've had one of the best ideas. 10 years later, when she came to see how well I was doing, we're still on beautifying the ideas. Thailand had gone much further in implementing some of the half-baked ideas that they had at the time. So we have a problem. And I think that, again, our system of governance is not, it's the philosophy of change that is a problem. That is a problem. The president signs into law. It signs a policy into law. It takes, on average, 15 to 20 years to have the text application. You ask anybody, no, Papa, you know, man can call a text application. It should almost happen immediately after the law is signed into action, so that people can exactly benefit from that. So it's this inertia in having to do things. I don't know how we need to overcome it, but we have to make a change in philosophy for the philosophy of change itself.
Thank you very much, Professor. Thank you very much, Madam Kechadi. Thank you very much, Dr. George. He has gone for an emergency. Thank you very much, Dr. APA, for coming. Dear participants, we thank you very much for accepting our invitation. And we thank you for sharing your knowledge with us. Thank you very much, Dr. Dangwa, Dr. Petru, for coming. We have shared a lot during this session, and I think Cameroon can achieve universal health coverage if the right strategies are put in place. So the speakers are still around. Maybe if you have a few questions, if you want to clarify your doubts, you can just meet them maybe outside and just ask your questions. Thank you very much.